Let's go ahead. Whoa. Let's fill around. You have to put this down here, and here's some visceral sounds while you're during your operation, during your talk. We're going to continue Dr. Hanks's visit with his lecture on thyroid disease and the surgical approach to thyroid disease. Thanks, Brian. Dr. Hanks, you remember from his introduction yesterday, is the C. Bruce Morton Chair in the Department of Surgery at the University of Virginia in Charlottesville. He trained in. He went to the University of Rochester for medical school. He did his surgical training at Duke, the legendary residency there, and from then he went on to his career entirely at the University of Virginia, where he's chief now of Department of Surgery and a surgical endocrinologist there. He is on the board of Journal of Surgical Research. He's held several leadership positions, including positions at the American Board of Surgery. He's been a director there, and he's also been president of the Southeastern Surgical. And also during his part-time, he's also a JV coach at the West Albemarle JV baseball team. So, multi-talented, very engaging visiting professor. I count this as a success already. John, thanks a lot for being our Covey lecturer. Thank you very much.
Great, Don. Thank you very much. This has really been a lot of fun, and I want to express my sincere gratitude to the Covey family for allowing me to do this. It's great to catch up with them yesterday, and again, I won't apologize for my Wisconsin, roots, but Michigan people are in our family also. We talk to them, so, but not during the football games. So. But it's really a very nice honor, and I looked at the guest speakers that you've had before, Michael Brunt and Quan Du, and some real leaders, Patty Newman, and it's a real honor to be included in that list, and thank you very much for having us come. I guess I led off with a more depressing talk yesterday on burnout. Thyroid surgery is a reason I didn't burn out. I love thyroid surgery, so this is a labor of love here. I think that it's germane to talk about the surgical approach to thyroid cancer because I believe very strongly that thyroid surgery belongs well within the armamentarium of all practicing general surgeons. If you look, the American Board of Surgery tracks the caseloads of the residents that will be taking their boards, and there's some residents out there that will be sitting in a hotel room with people like me very soon, and thyroid disease and thyroid surgery could be part of that questionnaire. And the American Board of Surgery looks at the practice of surgeons in private practice as well as academics. And it turns out thyroid lobectomy and thyroid cancer is one of the top, probably within the top 10 of the cases that practicing surgeons do. So despite our colleagues in otolaryngology's interest in thyroid and parathyroid, and they are our colleagues, I firmly believe this is a general surgery area. So surgical cancer brings out a number of important areas to discuss. What I want to do really quickly is kind of go through the pathology, go through some diagnosis schemes, look at some of the surgical options, and then if time permits, there's a couple areas that are a little bit on the controversial side, like the status of lymph nodes and what to do with lymph node dissection, and we'll see if we can't explore all those. Thyroid cancer is out there. It's not, it's not as prevalent as lung cancer, but probably the caseload is in the neighborhood of 20,000 new cases per year in the U.S. We will show you a lot of good survival data, but there are people that die of thyroid cancer. And I want to really focus my talk really on the well-differentiated forms, the papillary carcinoma and follicular carcinomas, and take a look at that, because those are the ones that really, of cancers, take up about 90% of thyroid cancer. The interesting thing about the incidence of cancer, it seems to be drifting up. If you look from over the last 35 years or so, All histologic types seem to be drifting up over the last 10 years. Papillary, particularly follicular and the poorly differentiated, have a flatter curve. But you say to yourself, why could that happen? And I think one of the reasons, I think it's multifactorial, but one of the reasons are we have more sensitive ultrasound, we have more sensitive screening, there's more awareness of it, and there's probably no doubt that higher resolution ultrasound out in the office situation has something to do with that. But then if you look at the incidence of women going up and not so much men, that begins to say there must be another factor going, because why would women have an increased incidence? The mortality, gratifyingly, still remains very flat. So there's probably a number of different issues, and we'll talk about that in a sec. So if you think about thyroid cancer for the med students and the standard, PIM question that you get on the ABSite and stuff, the papillary is the most prevalent one, followed by follicular. The other two are medullary, associated with the MEN syndromes, but also can be sporadic. The anaplastic is a deadly cancer, but is out there, and probably the practicing surgeons, your department probably sees 1 or 2 of these a year, I would bet. And then there's some very unusual forms of thyroid cancer, which include lymphomas, which will show up in various metastases. But as I said, I'm going to kind of dwell on the well-differentiateds. The relationship of papillary and follicular occupying 80 to 85% and follicular 10 to 15% has held fairly standard over the last several decades, particularly in the United States. So I think that those numbers are still good and relevant. That is, the majority of the thyroid cancers you see will be papillary cancer, which has excellent survival statistics. And this is where I want to focus in. It is the most common malignant neoplasm of the thyroid. It has some very unique cytologic changes, which makes diagnosis very easy. They have these typical nuclear grooves that you see on individual cells, the intranuclear inclusion bodies or the orphananias. They have papillary projections of the Simoma bodies. Again, another good PIM question for your med students. And they have a high rate of local lymphatic metastasis, which gets to very interesting considerations for what kind of surgery we do. This is the classic H&E stain of a papillary cancer. Here's compressed thyroid tissue out here, some lymphocytic background here, and here's the papillary projections that are just really classic for a papillary carcinoma of the thyroid. The really big breakthrough in fine needle aspirations over the last decade or so are the findings that you can actually look at individual cell architecture on an FNA, and you can see the nuclear inclusions, or you can see the groove in the cells, and you can look at one cell and make a secure diagnosis of papillary carcinoma of the thyroid. So that's the powerful tool of fine needle aspiration. Now, you need to have a good prep, you need to have a good cytopath colleagues reading these with you. But when you see classic findings like that, you can make a secure diagnosis on an FNA of papillary carcinoma. And that stands in contrast to follicular that we're going to see in a minute. On the FNA, the Simoma bodies, which are just really the calcified tips of those papillary projections, when you see these Simoma bodies also, again, highly suggestive, not completely diagnostic, but highly suggestive of papillary carcinoma. So, as I said, the 3/4 to 80% of all thyroid malignancy, there is an association of radiation exposure to this. And I think that probably has another factor that has to do with increased incidence. When I was growing up, people my generation, you can ask about radiation exposure, and they treated facial acne and tonsillitis with 600 rads of radiation, external radiation, and those people that had even that exposure have an increased incidence of malignancy in thyroid nodules. People in Southwest United States were exposed to open-air bomb blasts before the Nuclear Proliferation Treaty, so there were open-air bomb blasts in the United States. Downwind, there is an increased incidence. One of the transplant fellows at UVA had come over, and he was from Saudi Arabia, and he would wander in my OR, every now and then. He was interested in thyroid. He said something about benign thyroid nodules. He didn't see them because all the nodules in Saudi Arabia at Faisal Hospital were all papillary cancer. I said, what are you guys doing out in the desert out there? You know, I wonder if there's that increased radiation exposure that is really germane to all this. Papillary carcinoma of the thyroid has, across usually all series, better than a 90% 20-year survival. So it's not a killer, it's a nuisance, and we're going to talk about that in a sec. As many as 30 to 40% of patients will have cervical lymph node metastasis, probably at the time of their diagnosis. So that's something else to keep in mind. I want to get back to that. They have distant mets, and say 2, probably the 14 is a little bit on the high side. But even the incidentally found papillary cancers can have a mortality involved with these. And some series show that the incidentally found less than a centimeter papillary carcinomas have this very low mortality, yet as high as 1 out of 6 of these can have documented cervical metastasis at the time. So we'll play with that in a second. Just getting back to the power of radiation exposure, while the Ukraine is getting a lot of news these days, those of us old enough to remember in 1986 the Chernobyl blast released an immense amount of radiation in the air off the strontium and cesium. And just downwind of Chernobyl, within the next decade, you could see this astronomical rise in number of cases. And so radiation exposure, again, I wonder if there's environmental exposures that have something to do with that increased incidence as well as sensitivity of ultrasound. But that's fairly compelling data. So the papillary carcinoma classically has the forms that I've shown you with the papillary projections. There are some other variants. There's what they call microcarcinomas. Every now and then you'll take out a thyroid goiter and there'll be just punctate dots of papillary carcinoma spread through those, and those are called microcarcinomas, again with excellent survival statistics. They have what's called follicular variant of papillary carcinoma, where instead of projections they look like follicles, and these really act more like papillary. Also, tall cells and insular are these unusual forms. The tall cell here, again, show the projections, but the axial projections of these are longer than the width, and so they're called tall cells. They probably have a little bit worse prognosis, and the insular papillary carcinoma also has a worse prognosis. Very unusual forms, and every now and then you'll see those, particularly if your pathology people are pretty sharp. In contrast, follicular thyroid carcinoma is about 10 to 15% of series. They're more common in iodine deficient areas. They don't have cytologic landmarks the way papillary does. Remember, the papillary, you can look at that nuclear groove and you can say that's papillary carcinoma. There's no such cytoplasmic, there's no such cytologic diagnostic features of follicular carcinoma. The follicular variant of papillary carcinoma, as I said, behaves more like papillary. So it's at the 10 to 20%. It's more in females, and they're a little bit, this is an older population. The follicular carcinoma is usually a solitary mass, as I said, in the iodine deficient areas. Their incidence of cervical mets is lower than papillary, and they have a lower rate of multicentricity, but they can be a little bit more aggressive. This really requires, because you can't make the diagnosis off of cytologic architecture, this requires seeing the location of where the cancer is. So classically, you need to see that the follicular cells of that mass are invading, at least invading the capsule, or are angioinvasive or grossly invasive. So this is not something that's easily picked up on FNA or easily determined by frozen section in the operating room. And what they're looking for is, here's the follicular carcinoma here, here's the thyroid capsule out here, and encroaching through the capsular wall into the surrounding architecture are these nest of cells. So they need to see that the groups of cells are going through. And these, otherwise, if you looked at an FNA, all these cells would look the same. So it's the capsular invasion that they're looking for. So it's very difficult to diagnose by pre-op FNA. Follicular carcinoma is more likely to spread hematogenously than through the lymphatics, as we mentioned. The incidence appears to be decreasing, perhaps with the fact that the iodine is more in the worldwide diet. And we're going to talk about the pre-op FNA. The preoperative FNA, when you get that FNA back that says, gee, you have follicular cells in it, probably you're still in the benign category. So 85% of these would be benign, leaving 15 to 20% of folliculars probably ending up being cancer. Not to say that follicular can't be an aggressive tumor. This is clearly an autopsy specimen of a patient I operated on or treated palliatively with follicular carcinoma. Here's his resected laryngeal area, and here all of this is follicular cancer. This is a cervical lymph nodes, and this is a clotted internal jugular vein here. So follicular cancer can be an aggressive cancer, particularly in older males. Then there's the subset, and again, you're probably going to see more questions on your absite about Hürthle cell carcinomas than you are going to see Hürthle cell carcinomas. But it's really a variant of follicular carcinoma, which has more oxophilic cells in it. The adenomas and carcinomas use the same criteria. In other words, you're looking for that capsular invasion of the oxophils. It's less likely to take up I-131. It's probably a little bit more aggressive, much like its follicular cousin. And so most of these will require total thyroidectomy once you have a Hürthle cell diagnosis. And this is just the follicles of a Hürthle cell adenoma showing the paler staining oxophilic Hürthle cells. So it's a follicular cell in origin. They're more hyperchromatic. They may have higher oncogene expression. We'll talk about that in a second. And they may have a higher tumor recurrence rate. This is still kind of being worked out. There's not a lot of large series of Hürthle cell carcinomas. I've seen a couple over the last 20 years. Treat them pretty much the same as follicular cancer, and we'll talk about that. And here's a Hürthle cell cancer that's clearly invading the capsule of the thyroid around here. And so, again, you need to use the same diagnostic criteria for the Hürthle cell carcinomas as you do for follicular. There's a lot of interest in thyroid oncogenesis and the idea that can genetic mapping or can genetic evaluation help us, because, as I said, the fine needle aspiration, if it gives you a papillary carcinoma, that's great. But what do you do when you have the follicular cells and you don't know what it is up front? Is there any help with looking at these gene mapping sequences that will help us with diagnosis? And particularly over the last 10 or 20 years, a lot of the genetic makeup of these thyroid tumors has been elucidated. There's three main classes of the genetic expression in the receptor and the signal transduction pathways and in tumor suppressors. And they're beginning to work out fairly well to say in the receptors that when you have the RAF protein in the B class or the BRAF, and you can identify that preoperatively either in your FNA or on thyroid lobectomy, and then you're considering completion thyroidectomy. If you have the BRAF mutation here, you may be dealing with an aggressive type of papillary carcinoma, and that's begun to get worked out. The RET oncogene here is associated with papillary carcinoma, particularly in the patients that have had increased radiation exposure. The RET oncogene has been very helpful in determining the MEN2 or the medullary carcinomas and helping the diagnosis of that, to where actually if the patients have the RET oncogene in an MEN2 or a medullary carcinoma family, you can make the diagnosis of medullary carcinoma just off of that, the existence of that oncogene. Tumor suppressors are also very important. The P53 suppressor gene, if that's apparent, you're at risk for a very poorly differentiated carcinoma or an anaplastic carcinoma. So the work on this is ongoing, and I think it's going to be very important and maybe help us understand some of the transition of normal follicular thyroid cells and how they transition, and at one point along the pathway we might intervene. If you have a thyroid mass and you have the oncogene, can you really begin to predict in advance and intervene? So I think this is an area that's being worked out. And what would two particular areas that are important over at Hopkins, Martha Zeiger has been very interested in looking at groups of genes using microarray cluster analysis, and also looking at molecular markers in the fine needle aspiration or in peripheral blood, say in postoperative cancer patients. And so this is probably where the new molecular technology is going to take us in the next couple of years. Just very quickly on microarray technology. You can use this as cluster analysis to look at a lot of genes and group them and say, okay, if we don't have one gene that's telling us what the pathway to oncogenic expression is going to be, can we look at groups of these, and can we distinguish various tissues that are otherwise subtle, and then get a better diagnosis of cancer. And again, a bit of a complex slide, but this is a microarray analysis that Martha Zeiger published, and these are tissue samples over here on the right, and this is the genetic expression, either blue or red, as to whether or not that gene's expressed. So here's a whole group of genes. The top half of all these, down to about here, these are all tissue samples from benign adenomas or non-cancer specimens, and then below this, these are follicular carcinomas and papillary cancers below the line. And you just kind of squint your eyes a little bit. I know it's kind of like the old radionuclide scans, but you can see that the genetic profile of these benign lesions over here are red where these are blue, so that there's a different genetic expression. And can we mathematically cluster these and figure out which groups of genes might even be more sensitive in diagnosing cancer preoperatively? And you can take three gene expressions and look at those, and you could begin to come up with some mapping things that will predict preoperatively on a fine needle aspiration or perhaps core biopsy as to whether or not you got cancer. Again, work in progress. We already talked about the BRAF mutation and its association with much more aggressive cancers, and the idea of looking at individual genes is all work in progress. So this takes us to, okay, let's get out of high-powered math and cluster analysis and say we got a patient with a thyroid nodule. Okay, how in 2014 are we going to work them up, or how are the residents going to explain a workup when they're sitting in the hotel room and a guy with a nice tie and coat is asking you, on your oral boards? So a lot of times these patients, I talked about the increased use of ultrasound, but patients will come in with a palpable thyroid mass or picked up on ultrasound. And here's a typical ultrasound here. Here's your trachea, and here's a solid thyroid mass. How do we go through the workup of that? And we know that ultimately, this mass is going to look like this grossly. This is a solid, meaty mass in a background of otherwise normal thyroid. And let's back up a little bit and look at one of the tools that we use, which is fine needle aspiration, which has been a big breakthrough, particularly in the last 20 years. And this is the UVA experience with delineating the new category, which is called the Bethesda category. And I think that people, if you're not familiar with it, or you're probably your path people are beginning to read it out now, but it's kind of like the BI-RADS for the mammograms. But you have categories really from low numbers to high numbers with suspicion for malignancy. 1 is really just non-diagnostic, kind of a swing and a miss. But 2 is from benign up to suspicious up to 5. And then a 6 is kind of, it's malignant, where they obviously see something like the cytologic grooves. But if you get back these 2s, 3s, and 4s, what do you do with them? Well, here in a large review, the UVA cytopath people, which are very good, show that the number of cases, the percentage of cases that they have, represent a fairly wide spectrum. And then when you look at, okay, for all of the different Bethesda categories, how many are malignant? Well, when you call it malignant, the malignancy rate is, 98%, so that's pretty good. But when you say the lower categories, the 2s and the 3s, here's a Bethesda 3, which is atypical cells, well, you still have a 16% or I got 18%, 17, 18% incidence of malignancy in there. So that's fairly high rate of malignancy in the lower Bethesda category. Suspicious gets you, you still have a 25%. So FNA, is helpful, but it's not 100%. And again, just the idea that you can make the call off of a nuclear groove with a high rate of sensitivity, but anything less than that, you're still out there. So here's the busy algorithm, okay, that we use. Now, at first it's daunting, but you sort of break it down into this area here. You're evaluating patients with local symptoms. So you have a presence of a thyroid nodule. You take your history and physical. Radiation, family history, as I said, extremely important, okay. And then what you're basically doing is the first thing you're doing is you're looking at, is it functional, okay. So the first shot out of the gun, because I ask the residents, what are you going to do first? They say, oh, we do a fine needle aspiration. Take a look at the function of this thing first. The first thing you do is you look at your thyroid function test. If you are hyperactive, remember there's going to be a subset of these. Now, mostly your endocrine people are going to be seeing, but I promise you these are coming into surgery clinic, okay, with borderline or clinically high T4s, T3s, and suppressed serum TSH. These patients need to get scanned. They probably have a hyperactive nodule, okay, and they can be treated. If it's a hot nodule, they can treat that either with suppression or ultimately surgery, okay. If it's diffuse, again, these are effectively treated. Occasionally, surgeons will see a hot nodule. They've attempted to treat it, they can't, and they want it out. That's fine. But on the functional side, you're going to try and treat this. Over here, on the normal side, you have normal thyroid function tests. Well, then you're worried about whether or not you're on a cancer side. A cancer is not going to present as a hot nodule, okay? So you have your normal thyroid function test, then you go to ultrasound before you pull your needle out. And why do you do that? Well, basically, if this is smaller, you're going to follow it. Or if it's cystic, you're probably going to aspirate it. There are thyroid cysts, okay? By and large, those can be aspirated if it's a pure cyst. If it's solid, then you go over here, then you begin to use FNA, and then these are the Bethesda categories. And frankly, it really depends on the doc that you're working with as the category as to whether or not they want to go to the OR or not. Clearly, if they have a very high, a 5 or a 6 in an older male, you're going to want to go ahead with taking that out. So to me, it sort of simplifies a complex, a rather complex algorithm. But we've really basically keyed it in on the ultrasound and the FNA. So it's really quite simplistic the way I look at it. What do you do with this? This is a complex nodule. This has cystic components and solid components. So this could be a colloid nodule over here, but could there be a papillary carcinoma in here? Yeah, I mean, that's the thing. These are heterogeneous. So you have to kind of use your common sense and index of suspicion. So what is the thyroid cancer guidelines in the American Thyroid Association? They basically say, well, if it's a solitary nodule and the thyroid function tests are elevated, you could scan it. And like I said, I probably don't use the FNA, although they say you can. I don't think it's worthwhile. If you have normal thyroid function tests and it's solid, particularly in older males, you would consider FNA it. If it's cystic, you aspirate it. If it's multiple, you pick out the dominant nodule and consider using the molecular markers. And again, the molecular markers are a work in progress. All right, so let's talk a little bit about the prognosis of what we're dealing with then when we make these diagnoses. There's lots of different categories that show you the prognosis, but by and large, you're dealing in papillary carcinomas. You're dealing with something that's not a killer, but it is cancer. I'm going to I've selected out the Mayo Clinic experience because that's the largest group that's been followed the longest. It's the data that I'm going to show you here is a little on the old side. These were published about 10 years ago, but I still really like them. So here is 40 postoperative years at the Mayo Clinic on 2,200 patients of papillary carcinoma, and nobody really has numbers like this. And they go back to 1940, up almost to 2000. They published this 10 years later. This is all causes of death. Here's your observed versus expected. These are very close, although if you run the statistics, they'll show you that this drops at year 10 or something. But again, it's very close. And cause specific, in other words, dying of thyroid cancer, is very unusual. And you look at there's a couple of different staging categories, but I'll show you that a number of things basically are the same with that. The Mayo Clinic staging category and the Leahy Clinic staging categories both have parameters that deal with age and sex and whether or not you have distal metastasis. If you're in a low-risk group, you have a very good good survival statistics, and these are the majority of cases. The same way with the Ames. If you're in high risk, though, you do have increased chance of dying, although these are very much the minority of large series. And then if you look at risk group definitions, what's really important is age, the size of the tumor, as well as the possibility of distant mets, and the histology, particularly if it goes over to follicular. You put all this together, and if you're male, over 45 or 50, you're probably at a higher risk. And I put that into my thinking that a younger lady with a solid nodules not going to have, as high risk for a bad outcome with thyroid surgery, but you're going to be more suspicious for an older male. And a lot of this stuff breaks down in that area. So the low risk are the smaller lesions, as I said, particularly a younger female. And if you look at this category, you have really less than a 1% mortality in these tumors for the well-differentiated at 20 years. The higher risk are larger in males, and they can pick up into the 30s or 40s mortalities at 20 years. And again, if they come from an iodine insufficient area or they've had a history of radiation exposure, those numbers go up. Most of the large series have a large preponderance of the low-risk categories. And this holds true in Asia. Here's a 12-year follow-up for surgical resection. The low-risk patients do very well, have a low cancer death incidence, but the higher risks have a definable cancer death and a much higher rate of recurrence. So if you're in the high-risk group, you definitely need aggressive surgery and aggressive follow-up. This will pull out a little bit. This is U.S. data that looks at the various histologies. Clearly, you want to separate out the anaplastic cancer. It's the one that really affects your mortality figures. So when you look at mortality for cancers, you want to really make sure that you're talking about the well-differentiated. And in this group, even the medullaries and the sporadics, they drop out a little bit below the well-differentiated, but they're clearly different than anaplastic. So what are the surgical options? How do we approach surgery for that? You have a number of different options, and you'll read about this. My way of thinking is nodulectomy is just not a really good idea. At least a complete lobectomy is not a great idea, because if you think you have a benign nodule and it comes back cancer, then you've at least got to go back into that area and take that nodule out. So I think if you're going to do anything, you want to do a lobe. Lobe and isthmus versus near total versus total, and we're going to play with that just a little bit. Your typical diagram of your lobectomy, dividing it on the midline. But when you take the lobe out, you're going to take the entire lobe out, so you have to be aware of the anatomy. The head's up here. Here's an operative shot. Here's a very nice demonstration of the recurrent laryngeal nerve going over the inferior thyroid artery. The parathyroids are right next door. Classically, your parathyroids are going to be within about 1 centimeter of this in the tracheoesophageal groove. But if you're into this business, I really insist that you see the recurrent laryngeal nerve and you preserve the parathyroids. So the advantage is if you say that you have a nodule and you want to just do a lobe and then find out what it is, well, if it's less than 1 centimeter, that may be all that you need to do. The disadvantage is that if you're not sure what it is and it comes back cancer, then you got to go back to the other side and do the completion thyroidectomy. That's not the worst thing in the world, but that's another reason you want to have done the complete lobectomy on the one side. Total thyroidectomy takes care of bilateral disease. Obviously, you can't do really do effective I-131 therapy unless you've done a total thyroidectomy. And you can use a marker of thyroglobulin for any kind of recurrence. The disadvantage is that your rates of recurrent laryngeal nerve injury and hypoparathyroidism will go up in total thyroidectomy series, but if you're a surgeon that's doing this, you should still have a very low rate. So let's go back to the Mayo Clinic and get after the first question I was looking at is, so what's the really, over a large series, over nearly 50 years, what are the patterns of treatment? And this is really an intriguing report because, again, they look at their choice of procedures and the use of radioactive iodine. and they go over their experience going back into the 40s. Remember, so they break it down into 4 different categories. In the 40s up to 1954, they basically just did lobectomies, didn't really use a lot of radioactive iodine. In the 50s, for the next 15 years, they switched to doing more aggressive, they do more totals, but they're not using radioactive iodine. And here they start doing more totals and they add radioactive iodine onto it. So they have their own historical controls. Now this is not randomized, and it's all kind of, well, it's a retrospective review, but it's a prospective change. But you can begin to look at the effects of surgery and add on radioactive iodine. And just kind of a busy graph here, just if you look at the lobectomy experience here back in the 40s, they're doing a lot of lobectomies, and these just sort of drop out. And then they, starting from the 40s, they were doing less near totals and totals, and over here in the later series, they're doing more of this, just to give you an idea. Before 1974, here's the incidence of those using radioactive iodine. Before 1974, they're not really using a lot of radioactive iodine. So in the latter series, they're using more radioactive iodine on the more aggressive. And interesting, the first thing that you notice is of all comers, their 20 and 25-year survival over all comers really doesn't change a whole hell of a lot. They have good experiences, but you begin to think, what's the difference? And the rate of recurrence at any site remains low, between 11 and 14% here. Then you break it out by mortality and recurrence, and you take the mortality figures of the first decade, and this is this number, and then all the others where you added surgery, the same surgery, total thyroidectomy plus radiation, and that curve doesn't change. So the biggest jump is when you start to do more aggressive surgery. Same here with recurrence. As if to say that the addition of radioactive iodine really didn't add on to the fact that doing the more aggressive surgery, the total thyroidectomy. And that gets gets your radionuclide people kind of excited, you know, when you show that data. And there's other data that says otherwise. But this is one of the longest series, and I think it stresses the point that a well-done total thyroidectomy is really the key to all this. I don't think it proves that you shouldn't use radioactive iodine ablation. But in the United States, this is probably one of the largest series, and I think it's really kind of interesting data. And like I say, when I show that to the endocrine people and the radionuclide people, they get a little squirmy, but it's interesting. So since 1950, the Mayo Clinic had excellent outcomes. The 40-year cause-specific mortality and total recurrence were 6 and 13%. The only significant improvement was between the first and second group, where the 20-year drops from 10 to 5 and the recurrence from 24 to 12. So the increasing use of radioactive iodine did not seem to improve on more extensive surgery. I don't think that proves it, but I would just say this is a good American data showing that the bedrock really is total thyroidectomy. What do we do with the smaller papillaries? And here's an interesting experience from Europe. You find the small papillary. What does that mean? Does that have any significance? Well, 292 had this near total thyroidectomy, but 72 of these 300 had persistent or recurrent disease, and 68 had local regional mets at the time in the lymph nodes. So multivariate analysis shows that persistence or recurrence is really associated with the sclerosing variant, papillary lymph nodes at the time, which was 30%, which those are the ones that got lymph node dissections. But in this smaller group, even though there might be more aggressive variants, no patient died with their disease with a small initial primary. And these are just a number of series in the United States and in Europe that basically show that for the well-differentiated cancer that are followed for a long period of time, this just confirms the same thing, that really you want to do a total or a near total, and every time they compare it with less than that, they have better survival statistics. So the American the American Thyroid Association comes out with this for the extent of surgery. For patients with thyroid cancer less than a centimeter, the initial surgical procedure should be a near total or total thyroidectomy unless there's contraindications to that. Thyroid lobectomy alone may be sufficient for treatment of the small, less than a centimeter, low-risk unifocal intrathyroid papillary carcinomas in the absence of prior head and neck radiation or radiologically clinically improved cervical nodal metastasis. So less than a centimeter, you can probably get away with a lobectomy. Greater than a centimeter, then you probably buy yourself a total thyroidectomy, and I think the data shows that. Let's talk a little bit about lymph node status. Remember we talked about earlier that it was pretty common to find patients with papillary carcinoma of the thyroid, no matter what the size, remember the data shows no matter what the size, you have a 30 to 40% chance of documented cervical lymph node metastasis at the time. Most, but not all, of these studies show that there's really no significant effect on survival or recurrence for patients with nodal mets. And there's this Japanese report we'll talk about in a second, is whether or not you should use prophylactic lymph node dissection. And clearly, lymph node dissection in the lateral compartments is appropriate for those patients with palpable cervical lymph nodes. And this is this study that's really sort of fascinating. These are the patients that had a prophylactic lymph node dissection. Now this is over 200 patients, 235 patients. Now 130 of these had palpable thyroid tumors, palpable primaries, and 101 of these were small enough so that only ultrasound followed. So these patients were followed for over 5 years, and in this group of 235, 50 of them had central lymph node dissections, and 185 across the boards had either modified or a modified radical neck plus a central lymph node dissection. So what did they find? Of these 235, and again, these are negative clinical nodes. Nobody had palpable clinical nodes. It's important to remember that. Of these 235, 60% had at least micromets in the central neck, and 40% had micromets in the lateral neck, in the dissection. So half of those were non-palpable tumors, non-palpable clinical cervical lymph nodes, and 40% had micromets. Well, what did that mean? Well, there was no difference in the recurrence rate of these that received these surgeries, central or prophylactics, and a control group of 155 that had no neck dissection. There was no difference in recurrence. So I would say that probably prophylactic lymph node dissection really has, there's not proven efficacy in recurrence or survival. And you go back to the Mayo Clinic data and you look at 2 stages of thyroid cancer, of the thyroid cancers with or without distant mets, and whether or not they have cervical lymph nodes, and you look at their survival statistics, and it really breaks down that here's the T1 group, that the primary is contained within the thyroid. They don't have distal mets, and the group that has the findings of cervical lymph nodes at the time of diagnosis versus the others that don't, there's no difference in survival. Here's the stage 4s, same group, no distal mets. They have the same survival curves whether or not they have cervical lymph nodes at the time. So ironically, you would think that local cervical lymph node metastasis would have something to do with survival, and it doesn't if you look at it any number of different ways. So where do we come down on lymph node status? Therapeutic but not prophylactic lymph node dissection for papillary, I think, is reasonable. You might consider a prophylactic central lymph node dissection for the advanced tumors greater than 4 centimeters and gross extrathyroidal invasion, and that's probably apparent basically as a cleanup operation. And defining central is medial to the carotid arteries within the central neck and the anterior mediastinum. Lateral is defined as all lymph nodes in levels 2 to 5 out of the lateral neck. But basically, for the greater than 4 centimeters with extrathyroidal invasion, those are the ones that probably is a good idea to do a central lymph node dissection on. The obligatory picture of Dr. Coker, who I think probably set us all straight on thyroid surgery. It's sort of interesting to stop and think that really a lot of the advances in thyroid surgery have really come within the last 100 years, and how far we've come with things like just defining the need and having good survival statistics. Remember the initial thyroids done at the turn of the century in Europe were 15-minute, 50% mortality, big multinodular goiters. operations, and now we're talking about large thyroid cancers that have 99% 20-year survival. So it's really remarkable how far thyroid surgery has come. And again, just to wrap up, I think it well belongs within the armamentarium of general surgery. So I think that it's very important to keep the work up and the understanding of what you're dealing with well within your knowledge base as you go through any surgical residency or surgical practice. Again, thank you, Dr. Covey, for allowing me to come and visit with your family and give the lectureship. It's a true honor, and I really enjoy coming out here, and thank you very much. I'd be happy to answer any questions.
I think you'll find a better summary of thyroid disease and thyroid cancer. Son?
Positive. PET scans. Yeah. So it's the lung guys and the breast cancer surgeons follow up with PETs, and they come back and bingo, there it is in the thyroid. You know, our experience on operating all this, and I had an interesting talk with Monica Morrow up at Memorial Sloan Kettering. All the ones that we've done have been benign, okay? But Monica claims that in the breast cancer population, it's like they're seeing about a 30% incidence of primary thyroid malignancy. And I don't know if that's because they've had local radiation things. I think probably I would take the positive PET scan pretty much through the same algorithm. I'd take a quick look. If it's had chest radiation or something, it's probably going to come out anyway. Probably use an FNA and take a look and get a good ultrasound and look at lateral lymph nodes. By the time they get to you with a positive PET scan, the patient kind of looks at you and says, well, my doc says it's got to come out, right? And you kind of go, well, but I think I'm saying they're all benign. We may have seen one that's a malignant one, but my experience is most of them have been benign. And a couple have been like colloid nodules, and I can't figure out why PET scan would pick up in a colloid nodule. But there it is, it's positive. So I would put the PET scan, you're going to see more of them, and I just put them in the same algorithm. I take a look at them. Low risk, I'd probably just do a low or frozen, but if it's a higher risk and the oncology people want you to do a thyroidectomy, I think then you go and do it. It's going to evolve, and probably somebody's going to prove me really wrong here in the next 10 years, but that's our experience with it. John. We haven't really got a lot of the markers at our place yet. I'm sure probably Sally Carty may be working with more of them. We just haven't gotten our cytopath people are really into the Bethesda category. We're working with them. We can get BRAF if we really need to. We have to send them out and stuff. Basically, we're working right now, unless there's a real call for we've been sending those out. I go through that algorithm that I just explained for my decision making, and have not really used it yet. The young guy I was talking about who's coming in is working with Cytopath to get them in our place. I think if you had a BRAF finding on an otherwise Bethesda 2 or 3, and somebody that had history of radiation, I'd already used the first part of that to say, okay, that's going to be a total thyroidectomy. But clearly, some of those markers will come out. But at UVA, we don't have them in our armamentarium yet, and we're following that along. Sir.
Do you think that some of the reasons you're not seeing much difference in the ones who have the lymph node dissection versus those who don't, papillary, is because it's very difficult to take out the central nodes in a block? If you're doing breast, you can kind of take everything out around the lymph nodes, but it's difficult to take a chunk out of there, take all the lymph nodes, and not leave little lymphatics scattered around.
Yeah, and again, I think it's got a lot to do with how comfortable in your experience in doing a central lymph node. I think it's a good point. You're right. Dr. Covey rightly points out that it's, you do an axillary dissection for breast cancer, and then there it is, and you mark it, and you can do levels. And when it comes out of the central lymph nodes, sometimes they come out in pieces. I think it's a good point. I think it's the biology of the tumor also. I think the compelling data is, and there's any number of other studies, is there's micromets that are out there, probably in 30%, even as the data shows, even with the 1 to 1.5 tumors. What do they mean? They just happen to sit there. Is that a reason to give radioactive iodine ablation? You don't really know. And in order to find out the difference, because the survival statistics are so close, you're going to have large numbers to make the difference. But you're right. I think some people probably do different central lymph node dissections than others. When we do, and then there's the other part about it is a lot of the endocrine people are coming back from the meetings and say, okay, you got a 2-centimeter papillary. I want you to clean out the lymph nodes on that side of a central. And you go and you say, well, okay, they're probably, and you've done the ultrasound and they're not enlarged and they're not palpable. Okay, and you take them out and guess what? There's some micromets in there. Well, you just took them out on that side. What is that? You're going to give them radioactive iodine anyway. So it's, what do we do with the knowledge that we get? The pathologic knowledge. So I would say, well, that's only half of a central lymph node dissection. How does that help you with decision making? And I don't know, but it's things that patients are coming in, they're reading on the net, they'll hear from their endocrine, from your referral people that you kind of take into your consideration. But I think it's a good point. I think it just turns out the biology of the tumor is that it's kind of an indolent process. You need to tell the patients that, yeah, they probably have cells with it. But those, fortunately, are not killer cells. Those are cells that are a nuisance, and you've got to keep an eye on them. And how we evolve that, what the surgery turns into 20 years from now, dictated by mutations and cytology, I don't know. I suspect it's not going to change a whole lot, but we may get a little bit higher sensitivity in our preoperative diagnosis.
Some of the evidence is showing that prostate cancers don't need to be operated on. Some breast cancers don't really need to be operated on because you're not going to die from it. Autopsy series show a lot of people have thyroid cancer. That they didn't die from.
Yeah.
How many of these that we're operating on
don't need the operation? Great question. And you sort of go back and say, well, the cause-specific death that I showed in the Mayo Clinic was, didn't really bump down too much. You have only to see a couple of anaplastics where in the middle of the autopsy specimen, there's these foci of papillary cancer. And they may or may not have had a history of radiation. And you look at that, and you look at the path people and say, was that a papillary that lit up? Can these progress? And it kind of makes you scratch your head. Now, again, it doesn't prove the point because it's not lots of numbers of that. But there are groups that have, everybody has an experience of somebody with a small papillary that it blew up or it got more aggressive. And I think it's pretty well worked out that if you get a reasonable operation, a zero mortality operation with a low morbidity of hypoparathyroidism or a low morbidity of voice changes, that you're probably better off getting that cancer out and not having a high morbidity operation and then not worrying about it. But I think you're right. I think you could also say, well, that is somebody going to come and prove that you could probably just watch it like the prostate cancers, maybe that will come out. I don't read that in the tea leaves as you see presentations on thyroid cancer, particularly with the incidence of it going up. If the incidence is going up, nobody really knows if those are the aggressive subtypes or the more indolent subtypes, which might impact on your question later. I don't really know. I think it's a great question. Oh yeah, there's no doubt in my mind. Yeah, no doubt in my mind that in particular they're using the ultrasound because now you've done a thyroidectomy, 1.5 centimeter. You've done it like 10 years ago. Did a total thyroidectomy. Guy I-131. Guy comes back perfect, and they find a worrisome lymph node, and then somebody put a you know, an FNA in it. Well, they didn't find anything, but it doesn't look right. Well, are you going to do a prophylactic lymph node dissection on that? So those kinds of people are coming up. That's actually even more to your question is, now that's more aggressive surgery for lymph that really doesn't have a survival statistic. And there's no doubt that the office ultrasound by the endocrinologists, who are good people and looking for that, is coming up. I mean, Brad, is that your experience where you're getting more of these, you know, funny lymph nodes or funny even intraparenchymal thyroid things? And that's clearly driven by higher resolution ultrasound, you know. And that's a question we're also going to have to deal with. It's right down the same line. I don't have a great answer for that. I think it's got a lot to do with informed consent of the patient. You know, you say, okay, you've got this. I mean, I can do this, or we can continue to wait. You know, what bothers you the most? And you rope the patient into the conversation. And a lot of patients will tell you what they want. They'll help you with that decision making. You know, and so I think you can. I use that a lot if there's any head scratching about the question.
Alan?
If you were to tell us the data you consider, especially with radioactive iodine, what would your recommendation be? Who should receive radioactive iodine? I've seen size criteria, I've seen all kinds of different indications, but it seems as if it's a very variable practice.
Yeah. In my practice, we're driven, and Brad and I were talking about this yesterday. My practice is about 50% internal through the endocrine group that we work very closely with, and about 40 or 50% of practicing endocrine and general surgeons that I've known for years. Around our area, most of them want thyroidectomy and radioactive iodine. The patients come in with that, okay? So I don't really get in the way of my referring practices. What I will get is you've done a lobectomy for a benign lesion that ends up being an adenoma, and you find a less than 1 centimeter or 3 millimeter, you know where I'm going with this, you know, papillary cancer, and they'll come back and say, well, shouldn't you take out the rest of it and get radioactive iodine or something like that? And I think the numbers are very clear with that. And even if they come in with that question, I said, there is no data that shows that you really need that, less than 1 centimeter. We can follow that, particularly if ultrasonographically the remaining thyroid is clean, okay? So I don't usually get in the way of that, and I don't know what your experience is here, you know, Brad, or can speak up to it, but those people they've hit the internet, they've talked with their doctor. You know, they're very intelligent now because people are asking insurance questions, they're asking treatment questions, they're asking efficacy of treatment. I would say I think we've got pretty good results with thyroidectomy and radioactive iodine, and I would absolutely agree in the higher risk male over 40 with a well-differentiated, probably ought to get good total thyroidectomy. Over 4 centimeters, definitely a central lymph node dissection and radioactive iodine. It's a little bit harder when you have a smaller tumor in a 20-year-old female that you know is going to do well. But a lot of times he or she will tell you, well, you know, I don't want that. Or, yeah, I do want that, and that's part of the informed consent. I think in the higher risk things, yes, I feel comfortable with it. Lower risk, not so much.
All right, we're in the break now for the case presentations by the residents, but before that happens, I want to thank Dr. Hanks officially and thank him very much for being a great lecturer.
Thank you all. It's been a lot of fun.
This is a plaque that's permanent and stays here. This shows all the previous speakers for the Thomas Covey Lecture, and Dr. Hanks' name will be on it, and this hangs in our
Well, that's
our
really
conference
nice.
room.
This is a very impressive group, I got to say. Bob Udelsman and Chris McHenry and Charlie. This is great. Thank you. It's a really nice honor.
And there's some more tangible gifts of our appreciation.
Oh,
Take these back.
excellent.
These are
Thank
for
you very much.
All right.
Thank you
Dr.
very
Hanks, thanks.
appreciate it.
Yeah, thank you very much.